my name is Halima Siddiqui, and I'm the project coordinator at Health Nexus. So, Health Nexus oversees several provincial initiatives related to FASD. The FASD provincial website, where you can find recent and up-to-date information about what's happening, learn more about resources and tools, and find out services available in your local community. We also allocate subsidies every year to 40 plus support groups for individuals with FASD and their families. And we designed an online training for service providers from various sectors, including healthcare and nursing, education, mental health and addictions, justice and corrections, and community and social work. Before we start the presentation, I would like to begin with a land acknowledgement. We would like to begin by acknowledging the Indigenous people of all the lands that we are on today. While we meet today on a virtual platform, let's take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous people and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nation people that call this land home. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we can each, in our own way, try to move forward in a spirit of reconciliation and collaboration. I'd like to begin by introducing our speaker today. Dr. Lori Vitale Cox is a community researcher and clinician who works in Elsipogtog First Nation, where she's the director and founder of the Eastern Door Center that opened in 2006. The ED uses a two-eyed seeing approach to diagnosis, prevention, and intervention of trauma related to neurodevelopmental disorders such as FASD, ASD, and ADHD. Lori has been active in FASD research, diagnosis, and intervention for many years, designing the medicine wheel tools and the TES, two-eyed seeing assessment wheel, in collaboration with the FN elder on the team, Noel Milia. A few years ago, she was appointed as adjunct professor at UBC Department of Pediatrics, Faculty of Medicine, where she is collaborating with the faculty there on the CIHR research. At the present time, she's on a national FASD expert panel of the Canadian Academy of Health Sciences. Oh, sorry about that. Canadian Academy of Health Sciences, charged by the Public Health Agency of Canada to inform national FASD policy and the FASD bill that is presently in second reading in the Senate. We are pleased to listen to your presentation today, Lori. With that, I'll stop sharing my screen and I will hand it off to you to do your presentation. And if anyone has any questions, please let me know. I can provide more information in the chat.
So the Eastern Door Center offers multidisciplinary elder-informed healing services for FASD and related disorders. We don't just do FASD. We do complex neurodevelopmental disorders. Screening, diagnosis, prevention, and interventions, and we try to integrate a medical perspective with a community cultural practices. So the concept of two-eyed seeing informs our work. And that is a concept that Elder Murdena Marshall brought to the community. The concept was originated by Murdena and Albert, who are husband and wife. Murdena's passed on, but Albert is still going strong, and he's quite a wonderful person. In two-eyed seeing, one eye looks through a traditional lens and one eye looks through a scientific lens. And in this way, you get more depth in your perspective. I really think it's a lovely way of looking at it. So I'm going to tell you a story about two brothers, and they were born to a mom who had alcohol use disorder, and she drank in both pregnancies until delivery. She was never told in either pregnancy that drinking might be harmful. The older brother, E, and the younger brother, who was 6 years younger. So by the time E was 10, he was smoking, sniffing, and drinking, and he had difficulty in school, often suspended. His family life was chaotic and very unstable during his early years. And at 11, he was sent to a Manitoba Youth Treatment Center because of the sniffing and drinking. When he returned to the community, he started stealing and he got in trouble with the law. And then he was sent to a youth correctional facility for a few months. When he returned to the community, there was no follow-up. There was no planning, no transitioning. And he continued the pattern of offending, stealing, assault, vandalism, mischief, drinking, uttering threats. At that point, he was sent to live at a group home in Moncton. While he was there in the group home with the structure, he started to attend school and work on basic skills. He was due to be released in mid-year April. Why they did released him in the mid-year, I don't know. But he tried to commit, he attempted suicide. So then he was sent to a psychiatric group home in Fredericton. And at 16, he returned to the community. He had no support, and he continued this pattern of being in trouble with the law, substance abuse, and unable to hold down a job. So we can see that in his story, the primary disability, which is the prenatal exposure to alcohol, the root of his problems, or many of his problems, combined with the context of his environment, the lack of assessment and health diagnosis, health services, the lack of appropriate interventions, and of family support and stability, which are all of these are the protective factors when somebody's exposed to alcohol, that led to the secondary problems, which are the school suspensions, the alcohol and drug problems, the periods of institutionalization, the mental health problems, the suicide attempts, the work problems, and ongoing trouble with the law. And you will see this in the research. There's a lot of secondary disability research that will show you that, concludes that this is the pattern. If an individual doesn't get the health services that they need in terms of diagnosis and prevention, then they'll have secondary, they're more prone to have secondary, originally they called them secondary disabilities, but they're called secondary problems. And it's interesting because the elders talk about that when they talk about the fabric of FASD in the community. What happens is that individuals who have unique needs and challenging behaviors, and they have difficulty learning and behaving, they're often perceived in our system as being problems and not perceived as having problems. But we need to remember that with adversity, children can't learn and they don't behave. If they're tired, if they're hungry, if they're cold, if they've been abused or feel unloved, if they can't understand the culture of the school, if they have unrecognized learning disorders, or they have undiagnosed developmental or behavioral disorders like FASD or other complex neurodevelopmental disorders, which we see a lot more with now the prevalence of the poly drug exposures with the kid. So the story of younger brother L starts out the same. By the time he was 11, he was smoking, sniffing, and drinking. He had great difficulty in school. He was often suspended. His family life was chaotic in the early years because of his mother's alcohol use disorder. And he began to steal. He was in the school when I was there, and, he was just this raw little boy. You could see it in his eyes, but when he was 11, when Elle was 11, the paths began to diverge. He was identified by teachers as part of an in-depth needs assessment at the First Nation school where I worked. I actually did that needs assessment. This was undertaken by community leaders, agency directors and elders and service professionals. They had gotten together in a committee called the Wellness Committee, and it was in response to a youth suicide crisis and inquest in the community, because in the 1990s there were chain suicides, and you can see the older brother's suicide attempt was part of that. It was just over and over through those years. And I started working in the community in 1995, 96, after I'd gotten my PhD. And it was clear that something was going on. The system was out of kilter. It was There had been psychologists hired as a result of the suicide crisis. They had two positions. I was the school psychologist, and there was somebody who was hired in mental health. In the terms of the school psychologists, they kept burning out. There were 2 or 3 before I came, because they kept trying to handle it or deal with it as an individual problem of the youth. But you could see that the system was off when you walked into the school, and you could see that there were many, many more problems than just learning problems. So I tried to figure out, because when you talked to the people involved, all of the key players and in here, the teachers, the parents, which is the first thing that I did, they said that there were multiple areas of need. And that's when I started to develop the medicine wheel tools, because it wasn't a simple screening that needed to be done to say, oh, well, these kids have learning problems or behavior problems. This was a context in the school and out of it. And so the first tool was the student teacher index, and then the teachers identify kids having multiple problems and problems in various areas. It was a 2-eyed seeing tool. And then when the teachers identified the kids, which was a rough screening, I needed to find out the developmental history. And the best person with that was the parents, the mothers. So they came in, we got consent, and they came in, and all of the children identified had experienced some area of developmental trauma. And the medicine wheel tools have been very helpful in screening, in diagnosis, and in treatment, and also even with the community, with the community development, to try to, it's like a way of getting participant action research in a way that's utilizes talking circles and a visual mapping of the community problem. And that we still use the tools in the community, both the student index and the developmental history. So it was very surprising to find that the areas of trauma, but the one thing that tied it together for the kids that were having so many issues was the disclosure of prenatal alcohol exposure and drinking and smoking. And I want you to realize that at that time, this really is upsetting to me. The doctors told women that moderate beer and wine consumption was safe all through the 1990s, all through 2000s until 2012, and even afterwards, when the SOGC in 2010-12 came out with guidelines that advised abstinence. So that point was then to get diagnosis, and we had 2 community clinics, and we collaborated. The pediatrician came to the community, and then the health center, and I collaborated with them to get so we could do these clinics. And the kids had many needs. Some of the kids were deaf, in one ear. They had vision problems. But overall, what we found, he was a developmental pediatrician, had been trained in various areas, and he knew how to assess and diagnose for FASD. And there was around a 20% prevalence in the school population. So that young one, L, he was one of the youth diagnosed with FASD. And at that point, we submitted a funding proposal to Indian Affairs, INAC, Indian and Northern Affairs at the time, for school support. And we were able to start interventions. They didn't even have a resource program in the school. And he had 45 minutes or more a day with individual support, but he participated in the small size regular classroom as well. There was an in-school reflection or cool out room. And we began the first thing we did was to make sure the kids weren't hungry, because many of them came to school where their physical needs weren't met. So we started a school breakfast and lunch program. It was hard to get funding for that. We finally did it through a foundation, because there's really no funding in Indian Affairs or in ISK for school lunch and breakfast programs. And we use like a lot of the, the traditional foods in that program. At this point, the mother also attended a culturally based treatment center in the community that had just opened, Lone Eagle, and she began a long-term stable relationship. And that we started to train the staff of all the agencies, Lone Eagle, Child and Family, and the Health Center. And we had community collaborations really to start a process to, an early childhood strategy at the health center where we would identify and screen the women for alcohol use. We would send them to a nutritionist, and she would give them food vouchers. We worked with justice because many of the kids were getting in trouble with the law. And I took a sample of 44 of the youth who were FASD and prenatal alcohol exposed, and 66% of them had already gotten in trouble with the law. And theft, break and enter, vandalism, assault, just like the older brother. And 12% had attempted suicide already. So, but the path of the younger brother diverged because with diagnosis and support of the school and then stability at home, the school suspension stopped, his drug and alcohol problem stopped, and his trouble with the law stopped. But there still were kids that didn't have, that still without the home stability, even with the support, they still weren't able to be in the school. So somehow, I don't know how this happened, but like, I think Creator was looking down, and I got invited to this session with Justice in Ottawa, and they asked me about what I would envision. And I envisioned this place where the kids could be healing on the land, place where they could be in touch with the elders and with their culture. It was a program to strengthen relationships, which is the concept of Nogama. It's a Mi'kmaq concept that means relationship to self, to the world around, and to Creator. And we were able, with the community donating a spot and the government like filling in various homelessness, Claudette Bradshaw's homelessness gave money for capital to build, to renovate the old farmhouse, economic development. We patched together this project funding, and we were able to have the kids who couldn't be in school and were getting in trouble with the law and who had been prenatally exposed to alcohol and trauma to this facility, so they didn't have to be out on the street. So we'd been able to help the younger brother, but the older brother, continued to have the trouble with the law. And at 21, he was facing a sentence of 2 years for assault. So the mother of the two brothers asked us to help. And we talked to the Crown and the defense. And it was funny because there was no way of doing that, but we actually just did it. And they presented a combined recommendation to the judge together. And he was able to go to alcohol treatment and then attended a day program in Nogama for 2 years. And during those 2 years where we were able to keep him there, it was a conditional sentence. He had no contact with the criminal justice system. If he started to drink, we held elder-led circles for him with his mother and the Nogama staff. And at that point, he was able to, it wasn't residential. He went home and slept, but we collected him in the morning and brought him there, and he stayed out of trouble. And because we had all the kids there that were getting in trouble, we had an external evaluation because we had a youth justice funding, and they did an external evaluation, and they said that the crime rate in the community had significantly decreased in the 3 years that Nogama had been funded. And it's a decrease because we had the kids and we're doing the interventions with them. So this is our elder, Peter Clement. He's passed on now, and he taught the youth traditional skills. There's another elder who's also passed on. Ray Solomon, he's related. He was an Ojibwe. His father, Art Solomon, is from Ontario. And he came every week and taught the kids how to make things. Here they're making hand rattles. That's actually the older brother in that picture there. And he made drums with the kids. The kids worked with clay. This young man was working with wood. He got a passion for carpentry, and he ended up going to college for carpentry and came back, to the community. We did cooking and baking to teach math. Everything was like hands-on skills, making medicine pouches, working the land. We had horses and chickens. And after 2 or 3 years of the project, the youth participants were all back in school. And at the end of it, 73% of them graduated high school and some of them went on to post-secondary school. It was quite successful. I have all the stats. That's the level of trauma of these young ones was high. The 3 R's that we worked with there were relationship and setting up routines like talking circles, and respect for where they were, not where we think as adults or as teachers they should be. And we can change outcome I've seen it, for individuals with FASD if we provide a stable and safe living environment with food, clothes, and love and relationship. We have interventions that are based on functional assessment, and we provide early and culturally safe diagnosis and support. A lot of times people miss the importance of diagnosis, but as the elders say, how can we prevent something that we don't see? So in next stage of what we did after the school interventions, the NOGMA, and the work that we did at the health center for the moms, the pregnant moms, we opened the Eastern Door Center for Diagnosis, Prevention, and Intervention and Related Conditions. We were able to do that because at that time, First Nation and Inuit Health Branch had money for diagnosis as well as intervention. They only did that for two years, because then they decided diagnosis was provincial, and so they took the training away. But we were able to send our team to Lakeland, which had a center already, and get trained for how to do the diagnosis, because it's really not that complicated, but it really is a little bit, it's hard to understand it. It's very operationalized, and we are able to do it. But here's our team in the beginning. This is our team. It was a wonderful thing. There's our elder. Half of the team is from the community. We have an elder healer as well as a physician. And they are really healers, they don't just come in and say the prayer, although that really helps in the beginning. It puts our heads in the right place, I would say. When we come in, we're all scattered, but when we start, it puts our heads in, he comes in and brings the spiritual component of the spirit of the child into our table. And that's, I think, very, very important. We have specialists, we have a school team, we have an outreach team, as well as the diagnostic team. Our prevention model is quite distinct from the public health agency model. It's a 7-direction medicine wheel approach. The public health agency model for prevention of FASD, it focuses in the women preventing. FASD is 100% preventable condition, and it focuses in the mom, stopping the mother, helping the mother not drink. If you prevent the mother from drinking, then you will you'll prevent FASD. That, of course, it's really necessary. All of those elements of providing support for the moms is really important. But what happens is that then there's a way in which it if the mom can prevent it, there's a way that it pins the condition on her. And it's not about it. Prevention is more than that. It takes in our prevention model, which really came from the community, takes in also generational and family system healing. It takes in preventing those secondary conditions that you see. It includes the fathers as well as the mothers. And it includes the leadership training for the youth to help them with service to the community and their own self-esteem and understanding of their gifts. So in the North, we have the prevention, the awareness piece, the trying to improve the determinants of health, education, training for physicians, and we want to reduce the cultural and spiritual risk factors. To the East, we have reduce the effects of the prenatal exposure even before you know that you've done the diagnosis. So we do like screening from the school when they're 3 and 4 years old, and they're just coming into nursery and kindergarten. We have a group kind of screening with an OT and an SLP. And then you might have functional delays. And then you give interventions on those functional delays, and it can ameliorate or it can reduce the effects of the prenatal alcohol exposure, because the brain at that point, when they're young, the brain is very plastic. It can help itself, it can heal itself in a way. Different networks can be created. So you do pre-diagnosis prevention interventions there. Then you want to prevent the secondary conditions. So you give the early diagnosis, the early screening in the school, and the support. And then you have in the West, prevent the generational FASD, prevent the youth with FASD having another baby with FASD, and also the mother. When you've identified the mom, you don't just identify the child. Like when you identified the mom drinking and you diagnose the child, you've also identified a mom who needs help. So you try to give support, and that's where our family outreach comes in there. And then there's the directions of below, which is helping the child with their self-esteem and understanding their gifts, and then above, doing service. And that's in the Micmac tradition, there's really 7 directions rather than the 4 of the medicine wheel. And I think when you've been involved with a condition for a long time, you understand that FASD is not just about providing diagnosis and then going off your merry way. It's about the interventions and the programs, and also understanding that the context of it has to do with healing what we were talking about, the legacy of the past, which is the structural components that are affecting how the alcohol is manifest. If you have a mom who drinks, who gets really good nutrition, there's research on this, she can drink the same amount, and as a person that has very poor nutrition, and the person with the good nutrition will actually have less clinical damage. The baby will have less clinical damage than the baby of the person who has generational long-term nutritional deprivation. Now, that's not saying that it's a poor people condition, because if you have a very rich person who happens to be dieting and not eating because they want to be skinny, and they're smoking and they're drinking a lot, you're going to have a baby that's very affected. What does matter is the context of it. We can provide good food to our pregnant moms, we can provide early interventions for our little ones who we know the moms drank or did drugs when they were pregnant. It's something that we can do as a society to alleviate this. And so we really need to understand that the social structures that continue today to engender inequalities in Canadian social institutions are there. They're still there. And we have to ensure that the needs of people, especially those with trauma-based disorders like FASD, are fully met. Even with the the little that we're able to do, and I'll talk a little bit about the gaps, in our services, but the suicide rate has significantly decreased in the community. We don't have chain suicides anymore. We do have some kids that I deal with crisis, all the time with these young ones, but we step in and we try to find a situation to help them. They're not just left. So right now, I'm dealing with, and mostly there's abuse, trauma of some sort at the root of it. But we try to find a way we work together to find a way of helping the young ones. The youth high school graduation rate has increased. We have community-based services and specialists right in the school. We have a specialist team with an OT and SLP. We didn't have anything like that in the beginning. We do training for school and health justice professionals. We have earlier interventions, I was explaining, at home and school. And the youth trouble with the criminal justice system has significantly been reduced, and the prevalence of FASD has been reduced. So in 1999-2000, when we did these two clinics for those 2 years, FAS with sentinel facial features, 5.3% of the kids were diagnosed with FAS. And what used to be called PFAS and ARND, which now would be FASD without sentinel facial features. I could explain that if anybody wants to understand that. It's 15.5% was 15.5. So a total FASD was 20.8% of that school population in 1999-2000. In 2019 and 20, I repeated the prevalence study. We had 0% of FAS, because what happens is that as soon as the women find out they're pregnant, they stop drinking, the ones who are drinking. And with FASD, we have 10.3%. So the total FASD is 10.3%, which is quite a drop. It's quite a significant. We also have reduced the stigma, because people with FASD, they're successful in the community, many of them, and they'll tell others that they have the condition. And so the fear of acknowledging it also may be part, the fear of it is part of the legacy of the past, I think, the shame of it. And really, as the elders say, we create what we fear. And often I think that the shame is part of the colonial process, because we internalize the shame, but there's no need to be ashamed, And I mean, the gifts of the kids are amazing, but we have these successes at the Eastern Door, but the young adults in the community, our services only go to 18. So the young adults with FASD have no support services, and they continue to get in trouble with the criminal justice system. And funding for, Jordan's principle stops at 18, 19. Whole family systems are affected, and we don't do family system healing. There's absolutely no money or recognition of that's happening. But I have lots of data on that. The basic social needs of the indigenous families in the community in terms of food security, good water, and housing, they're often unmet. And that is not something that should be in the 21st century, nor should it be outside of the indigenous communities, where we have rural communities where people have basic social needs that are met, where there's not access to any of the services that are needed to really start healing this problem. We have no core funding for Eastern Door. We're in a crunch right now with Eastern Door programs. We have no funding for the diagnostic team, Nogama Youth Healing Lodge, family outreach, but we've managed to survive by hook or crook, for 20 years. And many of the youth and children who've gone through Eastern Door medicine wheel assessment and interventions, they're now adults. They're working in the fishery, the store. They're even working in the school as assistant teachers. And they're avoiding the revolving door of the justice system, many of them. Younger brother L participated in leaders training he was an assistant counselor at Nogama summer camp. he also went back to the school and worked there during high school. And he has a job now. He's working with youth. He graduated high school. He's married, and his youngest child just this year is off to college. And what I've learned is that it's not a matter of changing the kids. Oh, these kids they're hyperactive. We have to try to stop them from their hyperactivity. It's a matter of remembering that if they're hyperactive, if we give them the right environment, that hyperactivity can be turned into hyperenergetic. If they perseverate and they do the same thing over and over, and you're saying, why are they making the same mistake? You actually, by a routine and ritual and repetition, working with them, can change that into persistence. There was a girl that I did an adult diagnosis on. She was from PEI. She managed to graduate university. It took her 9 years to graduate university. She still had trouble, even at 29, even after that, with handling her, very impulsive with handling money. But in her 30s, she learned. Her mom really helped her with that. It took her 72 lessons to get her driver's license, but she got it. She was persistent. She changed it. She had the right environment for that. Inflexibility can become commitment. The daredevil can become courage. The distortions and confabulations can become, rich fantasy life, great storytelling. I think it's up to us to try to identify the gifts and work the environment so that it supports those gifts, because we really can change outcome. But we have to work on ourselves when the kids are, melting down, and they will, and it's really frustrating, especially during those teen years and even early 20s. It's very difficult, but we need to be there. We need to have a sense of humor and keep our cool and understand that their central nervous systems are very sensitive, and it takes them. They're younger in spirit. Even kids with average IQs, they have a trouble putting their ability to work in the world. And so the behavior that you're seeing is a message to you that they don't know how to handle. They don't know how to communicate it. And you need to listen to it without judgment and be their rock, because they're frightened when they go out of control. We need to take one step at a time and remember that, remember that whether we're a parent, whether we're a teacher, whether we're in the government trying to change policy, just take one step at a time. And remember that the children have real gifts. We started because we don't just do the resource program. We want to develop their gifts. So we started like a Sistema program, and that's a violin. It's a classical music program. And the kids are some of the kids that are the best at the music are clients of Eastern Door. There are Sistema leaders. We have their art contest winners. We did an art contest for Sleepy Bear cards that I was doing. I was doing CIHR research to look at how to screen. And the two kids that won the award were both clients of Eastern Door. I mean, these are amazing. We have to remember that every person is a gift to us from Creator, and each of them has a purpose. And we can help them find that purpose by believing in them. Thank you very much. And I'll try to answer any questions that you have. But before I leave you, here's a quote. I don't know who Walter Barbie is, but if you've told someone 1,000 times and he still doesn't understand, then it's not he who is the slow learner. Because we need to find other ways to approach, our kids. So if you want more information and access to the tools, there's a website, www.easterndoor.ca.
Thank you so much. This has been such an educational presentation, and we already have a lot of interest and activity happening in the Q&A section. So I'll just go ahead and start reading out some questions from there for you to answer. So one of our attendees asked, I work in research of post-adoption social work support in the UK. And so the children with FASD do mostly have stable and safe environments, and yet are still struggling. So what would you suggest is missing in the support or structure around them to succeed?
Well, I think uh, they're, like I was saying, they're going to have trouble all the way, even people with a stable environment, um, because of the trauma and the way that alcohol affects these little ones. You're going to have trouble, 29 is when the brain stops developing. 29 for somebody with FASD is like 18 or 16. For, it takes a lot longer. It's very stressful for parents, adoptive parents, or uh, you know, biological parents. It's stressful because you expect the child is going to be independent at 18. They have a big body, they're physically mature, but their spirit, they're developmentally, they're not, they have ability. You can see them. They could graduate. I was talking to somebody who had an adopted child. She adopted at 3, and her child graduated with honors at 18, and she can't deal with him. It's very hard. You have the college graduate who they still can't handle money. They still spend the money before they go to the bus stop so they can call home. They max out their credit cards. You have to keep remembering and have hope. You have to keep remembering that it will heal. You have to keep at it, and that persistence. But sometimes you may not be able to handle it. The child may have to go into a group home. They may get in trouble with the law and end up, but you need to keep your love there and the relationship and keep with them. Keep that going. Don't abandon it. Don't give up. And you will see a difference in it. If you can take them through those hard times, and it's well worth it to do it. And I just have to say, personally, I'm married to somebody with FASD. I can vouch for the fact that it's very difficult, personally. But the gifts that he brings into the relationship far outweigh the difficulties. Although it drove me crazy until I knew what was going on.
Okay, so question number 2. FASD will always exist due to unplanned pregnancy, drinking. So surely the only approach is going to need to be prevention, but also ongoing support for a condition we will always have with us, question mark.
So what is the question exactly?
So they're asking if the only approach is going to need to be prevention, but also ongoing support for a
Well,
condition we will always have with us.
that's what the model that the community worked out. Instead of thinking of it as prevention, this is 100% preventable, like she's saying, it may be with us because of the way society is set, because of the way we relate to alcohol. I think we need to think of it as healing FASD. It's a little bit different. Healing as prevention, that's going to include all of the different aspects of it, which is help, we are going to go out there and try to, tell our young people about, conception. If give them the information that they need, train our doctors to understand about it, train our midwives, have people aware that if they're going to have a session on it in high school, young men and young women both, to understand about alcohol. And it's not just heavy drinkers. We do the screening for substance use disorders, but it's any alcohol when you're pregnant. So there's a lot of factors that go into it, but we can do work if we start to work together. And some people say, well, you're in a small community, so it's a community thing. But we live even in urban areas are broken up into small communities, and they have, if we did hub medicine, which we may have to go into with nurse practitioners to get our medical needs met, that's the perfect kind of approach, for this. So in big cities like Toronto, you'll have a community in the inner city and work with that community in St. John and New Brunswick. So I think we can, but we do need to work together to do it. Stop our silos, stop our the way we work is, you know, is very strange somehow, you know, because we don't want to spend money. The amount of money that was saved because we lowered that by 20, you know, we lowered it by 10%. I went back and calculated it. It's like, you know, $500,000 a year because of the kids that now didn't have FASD. It's a very expensive thing, but everybody will say, well, I don't want it and I don't want to spend it. It's in my budget. We have to stop thinking that way, you know. But it is always going to be prevalent because we're not perfect. You know, it's like our societies are not perfect. So we will have, and what I see in Elsie is that, you know, we are dealing with the problem, lowering the rates of FASD, and now we have complex neurodevelopmental disorders that seem to be related to polydrug use. We didn't have any, we had one kid with autism. Now we have like a lot of kids with autism. And it's not a misdiagnosis. It's just a different effect of different drugs they were exposed to when they were pregnant. We have to do more research in that.
Thank you, Lori. Next question is, when might the rest of communities and provinces use this excellent program?
Well, I don't know. I mean, we have I have to get out there and put it out. I've been so busy with like developing it and with the crises, and I haven't really put it into the literature so that it doesn't get out there, you know, but I'm doing that. I feel a commitment. I'm 76 and I feel a commitment now that I should really get it out there because it's really serving on this national panel where they said there is no evidence anything works. There is evidence. We know that this works and it's coming from the community. It's a very practical kind of approach. And I hope that we can have it, especially in Indigenous communities. I hope we can get money to keep it going and also to have other communities come and train, you know, in Elsie on how to set it up. And we actually did that. Somebody had heard me talk in a Cree, from the Cree community in James Bay. And we went up, the elder and I went up and we were able, they had a diagnostic clinic and it worked, it was there and it was going for many years. But during COVID, they had no money for interventions. It's like us. We don't get the money that we need, you know? And so it just during COVID, like a lot of things, it just went, you know, went away, like they stopped. But we can try to get this in other places. They do use the tools, the medicine wheel. I have like tools like the difference game cards. They're being used like in St. John. Some people are using them out west. The Yukon used the community development tool, and all of them are available online. There's even a digital version of the difference game cards, which are goal setting. They're really great. They're the kind of cards from the PCAP program, but there's a youth set that you can work. We developed a youth set for youth. So hopefully we can, you know, and we're welcome, like we welcome visitors if they want to come.
Thank you, Lori. Next question. So this person is seeking advice. They say our issue is being able to engage with youth at risk when they don't want help. For example, they don't want housing or programming. I want to keep using the methamphetamine. They have autonomy, but their choices are hurting them. Advice and ideas welcome.
Well, we're in the same, you know, we're in the same situation. And the only thing I can say is that you need to keep knocking on the door because you can make a difference with them in terms of the drug use. A lot of times they don't want to really talk. You have to get a trusting relationship going. It really is hard because one person is going to find it difficult. If we could have like programs like street workers, that's what we have, like the outreach that goes out, because the kids need to have advocates. They need to feel trusting. The root of a lot of the drug use is abuse. If you look at the core of it, which we haven't dealt with in our, you know, we haven't dealt with the adversity that the kids are, the reason why they're using, you know, the drugs now. And that's again, we have to change the consciousness of the policy people. And right now, and I think work on an individual basis. I mean, right now, I'm one of the kids that was very similar to that. And he's now in jail. And so he calls me. So I'm connecting. I'm going crazy. It's very complicated. He has no family support. I'm connecting, trying to talk to his parole officer so that he can get an elder to be with him, so that when he's ready, because he's not ready yet, when he's ready, that he can have develop the trust that he can, so that he can start the process of changing. I can see he has such ability and so much potential, as you can see with a lot of kids that are on the street drugs. It is a real issue. And the programs we have set up for the homeless youth, they won't take them if they're on, drugs. They kick them out. And so we have a real problem. I don't have any simple answers, except that we have to work to try to keep the relationships going with as many as we can, and work on a community, basis to help them. And policy-wise, understand it. So maybe have programs that do that kind of outreach.
Lori, the name of the game that you mentioned earlier, we have people who are showing interest in that. Could you provide the name for it again, and then I can put it into the chat?
The medicine wheel difference game. So there are these cards. You play the game with the kid goes through the cards and makes a pile of things that are important, things that would not make a difference in his life, and things that would. And the things that would are the things he's defining. Like, it would make a difference if I had a bed to sleep in. It would make a difference if I had friends. It would make a difference if people didn't pressure me into doing things I don't want to do. It would make a difference if my mom and dad didn't drink and take drugs as much. It would make a difference if I could read better. If I had someone to help me in school. And they make the piles, and they get to the top 3. And then you help them achieve the goal. It's almost like a self-assessment, but also goal setting. It's coming off of the PCAP tools, which really have a very good rate of success. There's a lot of research about it, and it's very helpful. They're on the website. You can like print them off and then put plastic around them and make the cards for yourself. You can play it on the web with a computer and have the kids do it. But there's the instructions on how to do it on the website. And John Howard, I may be giving a webinar about how to do it. Maybe I'll contact you at Nexus when that webinar is going to be, and then you can spread the word around or something. If people want to, take it, it'll be a free webinar.
So the next question is, thank you so much for this inspiring presentation. I'm interested in the children's response to the animals. What did you notice when the participants interacted with the animals?
Oh, that's an area of gift for the kids, I would say. Like, they're really good with horses. They're really good with all of the animals. And it's a way of, it's like a nonverbal relationship, and it sets up, and then they have a certain amount of control. It's very therapeutic. We give that as one of the recommendations on our team, is that they, that they will do like animal therapy. And even to the point, like, have a service dog or a therapy dog, horse therapy. It really works. It's very, very effective. And one of the areas like that they do well in is like to become a vet assistant, working with animals.
Thank you. We have a couple people saying that the medicine wheel difference game requires an access code.
It really doesn't. You don't need an access code. Just forget that part. We just put that there for when, when people were using it, a group was using it, that they could make an access code so that nobody else could see. But you don't need the access code to get in there. I'm going to talk to the web developer. He's going to come soon, and we'll see about I'll put information about that in there, but you don't need the access code. You can just it'll have the cards go and you can do the whole thing. But the best way, really, if you're not remote, this sort of gives the opportunity for people that are far away, and you could counsel them if you were not in the community. You could actually set something up. But the best way is to go and get the cards, which are available there, print them out, and then plasticize them, so that it's actually like a set of cards, for you. And yeah, I think that's the best way. I was doing a thing where I would send them out. It was costing $25 a pack from a local printer, and I would send them out with the instruction book. But he's since closed, and I'm so busy, I haven't got another contact. But again, if I can do that, I'll send you the information if anybody wanted to order or something.
That'd be great. Thank you, Lori. The next question is, we really like the 3 Rs. What would you say to someone who doesn't see relationships as being a key support to someone with FASD?
Oh, they really miss the whole thing if they don't see it, because you can if you form the relationship with a kid that's why I tell the teachers, don't do it by rules, do it by relationship, because when they have a relationship with you, they trust you and they will respond to it. If you don't work off of that, and also relationship to others, but also relationship to themselves, because in a way, one of the things, the way I think about the alcohol is when the alcohol, an elder once said that the womb, the baby that's growing, that's their first home. And what the alcohol does is it interferes with the nutrients. It interferes with the oxygen. And so that their first relationship with their mom is compromised. It causes a lot of stress, and the cortisol system is engaged, the HPA axis. That's what's happening. So even if the kids don't have damage to the physical structures of the brain, they often have damage. The regulation part of it is all off. And so it's associated with later in life anxiety and depression. And so you need to have that you need to keep establishing the relationship, which is where the child, it's like a rebalancing for the child. That's why they need to understand their gifts, because it's understanding who they are and rebalancing themselves. And it's from that they can grow. It's from that they can develop. It's like if somebody has a disability where they can't see or something, they develop, their ears become super sensitive. Their brain, they're feeling the tips of their fingers. You can see it, like in what neurons are there. It's amazing, really. And it's the same for kids that have been exposed to alcohol. They can develop, if they get the relationship to themselves. If you have a relationship with them that they can work off of, they'll relax. They'll trust you. And you can calm them. You can calm them when they're tantruming. If you can get the peace in yourself and harmony, you can actually work, through that. So it's something it's the work that we have to do with helping them, get there. Like there was this one little kid at Nogama, who had done $30,000 worth of damage to windows in the community. And he was at Nogama, and he was had a lot of trauma in his life, and he was a perfectionist. And when he was making it with Peter, he was making an airplane, and he got really frustrated. And we simplified the rules at Nogama: no hurting yourself, no hurting others, no hurting the place, the world around. And so he started to bang on the airplane with a hammer. And of course, that was like doing damage. So I said to him, Julian, you need to go outside. That's against the rule. Very calm. You can do that, but you need to go outside. He stopped, and he was able to take that airplane outside and then beat it to pieces. outside. But think of what he was learning, because he was able to control the impulse until he got outside. It was the beginning of a breakthrough with him, where he saw that he could control it. He had been very frightened by but getting the relationship, helping him see the relationship to himself was really key, that he was capable of doing this. So I think in a lot of different ways, I have many stories about stuff like that. He's now grown up. He has a family of his own. He's fishing. He does have trouble with his relationships, but he's a loving parent. He's productive. He still is impulsive. I was just talking about him last night with his sister. But, it's really important that we remember that, and that we don't lose our hope, and because it's rough. It's rough on parents. It's rough on people to raise a child with FASD, or who have been, prenatally alcohol exposed, even if they're not, diagnosed.
So the next question is, what tools do you use to support the grief and loss process of loss of the expected potential for both the caregivers and the individual with FASD?
That's a hard one, because we don't usually work on the grief of the expected potential. We usually work on what's there, and the gifts that are there, not on the loss that you see, or that you would say, my kid is 18, or look what I've done, or this person could be this and this and this. What we do is just say, like I was saying there, you work from where you are and see what you have, because usually the kids have some amazing quality. It's not, and the grief and loss that you feel, that's not what the child feels necessarily. The child will feel the rejection of it. They'll feel that if the mother feels that way, or the teacher, or whoever it is that's working with them feels that. But I think that the mom, the bio mom, if she feels that way, needs to work with herself, needs to get some counseling for herself, because the thing is that moms do the best they can. She may feel ashamed, or I've seen that, where there's a lot of being upset, but that's, even when somebody's like drinking, and there's reasons for it. So you work from where they are as well, and help them understand that. I think it's easier than, you have to deal with it. If you as a mom feel grief, I haven't seen the kids who have FASD feel grief. What I've seen them feel is anger. I've seen them feel, really, like I was just talking to the kid in jail, I'm stupid. I'm stupid at, when I'm trying to talk to him about the reasons why he's like, getting in trouble and stuff, try to counsel him with it. I'm stupid. I'm never going to be anything, Their self-esteem is very low. I don't usually see their grief at what has been lost. I feel the grief of loss when the kids don't have a loving relation. Like I've seen the kids say things like, they're on their own, they're little tidbits. They're 15, they're 16, they're on their own. The family has kind of thrown them out. And they say, doesn't anyone love me? Don't I deserve to be loved? And it's more the feelings of that kind of thing. The loss of the attachment, the loss of, but not the loss for what they could be. Our job is to show them what they could be, because they each can bloom like little flowers. I've seen it, happens.
So thank you, Lori, for this wonderful presentation, and for participants for listening from across the province. Take care, everyone, and please stay tuned for more webinars and presentations by Health Nexus.
Great. Thank everyone for me.